out with a single stent technique, and very few require a second stent. If I look at my own data, when I look at my own practice patterns around 15 years ago, I almost indiscriminately used 2 stents in these areas. And a large part of those, a large group of those patients, if I had to redo them again, I might not have put in a second stent. And I think this is a change in practice, this is a change in philosophy. When you look at the complex lesions, you can very well fall onto a provisional strategy, and that will hold you in good stead most of the times. But when you start getting into the double stent strategy, this will be a planned thing, and I think here imaging helps. Why is it relevant? Because in a provisional strategy, the only issue that is there is a loss of a side branch. And if you do have a loss of a side branch, you can cross over to a second stent strategy. But in a 2-stent strategy, the issues are increased rate of stent thrombosis, which could eventually cause death, and a side branch TLR, which is not a great thing to do, not a great thing to have, because it's not so easy to treat. So our first job for me with imaging today is to first figure out whether my left main is simple or complex. Here, imaging helps. And the next step I have is to make that complex angioplasty, if possible, simple. So what am I looking for in my imaging? I think this is something that is important. And if I look at the left main complex, the left main, the LED, and the circumflex, there are many co-founding factors which make it complex. But to make it very simple, imaging that you take from the left main towards the left main, LED to the left main, and circumflex to the left main, I think the images that are important are the core images, which is the first 5 millimeters of the artery of the LED, the distal left main, and the circumflex. And I think those form the core images. And those core images, what do they tell you? The core images tell you about the strategy and the devices to be used, because if you see a lot of calcium there, you decide to use rotablator, or you use lithotripsy or flextome balloons or whatever, what have you. If you see soft lesions, then you can get away without those very dramatic devices. But the core images never determine size. That means the size of the stent and the length of the stent is not determined by these core images. So the core image, then you go to the images on the left, which I pointed out in a brown shade, are the landing zones. And the landing zones come in the proximal left main and the distal left main LED and the circumflex, to figure out where is the best position to keep that edge of the stent. This is defined by plaque burdens which are less than 50%. It has to be a stable plaque. And it is these brown images that determine the size of the stents that we are going to use. So the size comes from the peripheral images, and the strategy comes from the central images. It is a core of angioplasty, and plainly it is the understanding of these zones which are going to help angioplasty. Now, taking into example, this is a very elderly lady who came in with an MI, and you can see a very severely calcified left main. It's a 1-1-1 with calcium, more than 90-degree angle, and thrombus right at that site. The question is, how do we use a single stent, and yet we have to save the circumflex? And therefore, for me, after doing a rotational atherectomy, which is almost mandatory in these circumflex, in these calcified left mains, because they would not allow instrumentation of IVUS or even a balloon sometimes initially. So you do a rotational atherectomy, and once you've got your rotational atherectomy, you get your images. And your images talk about the same thing. You can see that the image right to the left is your landing zone in the left main. The image to the top, which is 3.5 millimeters, is a landing zone in the LED. So that quickly establishes that if I have a stent that could be 3.5 at the LED end and 4 millimeters at the left main end, then I would hold this patient in good stead. I also can calculate the length of the stent that I require. But before I position the stent inside, it is important for me to see the central 2 images, which are the core images, because that tells me that I need a little more work to be done at that time before I can put my stent in. In this particular case, it's a short lesion in the circumflex ostium, is non-calcified. It's a very short lesion of less than 3 millimeters, so maybe just a small balloon dilatation. And and open it up and not worry about it. But in the distal left main, I'd still have work to do with a flextome probably. So based on these images, what we decided that this is going to be our strategy, and we did exactly that. If you can see on the left images over there, we did a flextome in the LAD. We took a 3-0 flextome of the circumflex mouth, where we did not let we kept just enough flextome in that to open just the ostium of the circumflex, not injuring the rest of the arteries, and got away with a single stent. As you can see in this angiogram, we had the opportunity to review this at 9 months when we changed the pacemaker for this lady, and she is doing well. Similarly, in this left main, you can see that sometimes we can use these images. In this, if I look at these images, there's a distal left main, there's LAD extension, there's circumflex, which is critically narrowed in the proximal segment. And most of the times, in 20 years ago, I would just go do rotablator in both these arms and put stents in both these arms. But now what we do is the LAD images, as I've shown over there, the core images on the left side, which is the LAD ostium, you can see the MLA is 6.5 millimeters. The carina is spared of disease. It's a stable plaque. The LAD looks good all across, and I feel that it can be saved. We don't need to engage this LAD in this angioplasty at all, which makes it a very simple single vessel, like a single across the LAD stent from left main to circumflex. And so when we look at the left main images, it actually, this is post-rotational atherectomy. You can see that the left main is significantly narrowed. And these are the definitions. You can see that the A and the F are the brown images, which are the landing zones, which are going to determine this extent of the stent and also the size of the stent, which is going to be 4.5 on one end and 3.0 at the end. And what you see is if you look at the blue, that is B, C, D, and G, E, and G. These images are the core images which are going to decide the strategy. The G decides that the LAD doesn't need to be engaged, so it's a single stent strategy. And the B, C, D, E says that there's calcium there which needs to be working on, so we would use a flextome or a lithotripsy balloon to fracture that at this in our present practice to get a delivery of this. Also, what imaging tells us is that from point A to point B, which is the bifurcation point, it's 14 millimeters. So one can actually appreciate in this patient, what we took was a 4 millimeter stent, which went in from the landing zone in the LAD, and we let it dip into the circumflex and then put telescopically put a 3.0 stent as a second stent distally and completed this job. This was the final stent diameter, 6.8, 8.3, 8.9, and 12.8. These are typically translated as normal nuclear stress imagings at the end of 2 years, and this patient is doing well, which is very, very important. Strategy. An angiogram which is as complex as this, sometimes when we look at the angiograms, the radiological imaging of the circumflex ostium is rather poor. And here I almost got fooled by saying that I could get away with a single stent provisional strategy across in this left main. However, what happens is when we actually finish rotational atherectomy of the LAD and go into the circumflex, and we look at the image of the circumflex, this IVUS image showed that there was a huge calcium nodule right at the ostium of the circumflex, which was impeding into it. Angiographically, absolutely not visible under any view, but IVUS-wise, extremely clear. And this changed our entire strategy from a single stent to a 2-stent strategy as a planned procedure. So I think it saved us the trouble, because it could have been difficult to kind of engage this later on. And so this is the result. So there's a change in strategy based on the imaging. Of course, in these complex anatomies, angiography is alone to tell you what kind of strategy you're going to have, whether it's, and these two cases, most of you would agree, would have to be 2-stent strategies completely. However, there are times when you think that you can get away with 1 stent. Angiographically, you think that 1 stent is good enough, and most of us are tempted to do just a single stent in our practice. But when you do IVUS, you can see that the ostial LAD is 4.6. And when you have this large carina, if you look at the circumflex ostium, the carina has a large plaque, not very commonly seen, but these are seen in around 20% of cases where the carina has a plaque. And if this carina were to shift with the plaque over there, this ostium would be further narrowed and compromised. So in this particular case, when there's calcified lesion, I think from a 001 lesion, it became, the IVUS actually drove it to a 111, and we used a 2-stent strategy. the technique of culotte, DK, and tap, whatever we use, I think the steps are important, and I think different anatomies will favor different technical procedures, and I think this also depends upon the expertise of the operator and his comfort level with the given procedures. But the most important thing is, what should we aim for as an end point? We know what to start with. What do we end for? Angiographic, all the trials have talked about angiographic endpoint, which is a success is defined as anything less than 50% is a success. But I think that's where we go wrong. And I think the Kang article shows that if you have to get right, you have to get a fairly large, and for that fairly large, you need to have a fully expanded 3.0 in the circumflex, 3.5 in the LAD, a 4.0 in the confluence, and a 4 or a 4 plus in the left main with a residual plaque burden of less than 50%. How is it easy to achieve this? Well, it is difficult, and I'm going to show you how. When you look at post-PCI imaging, how do you look at the post-PCI imaging? We look at the same diagram that we started with, and now you realize that the core images which are in the center are the ones where the sizes are important. These images were not important when we started off for sizing the stent weight, but to assess the result, it is those blue bands which are important. The minimal stent area in those areas are important. The residual plaque burden over here is important because it will tell you whether you undersized the stent or not, or whether you've underexpanded or not. Tissue prolapsing in these areas is often met with restenosis, so that is a serious problem, and you've got to make sure that you do not deform your stents while you do it. And even if you do it, sometimes it's too late, but you will be able to predict that these patients are going to have to come back at some stage, and you can keep a closer watch. Landing zones are defined as those brown areas are the ones where you look at the edge of the stent and you look at the edge plaque burden, you look cleverly for dissections and appositions. And I tell you, I completely agree with Rajesh that I have a serious inclination towards IVUS in left main because this is good and the 60 megahertz can kind of do a great job. The luminal area determines, and the luminal areas and the landing zones are going to determine what the areas should be in the center, because you need to achieve at least 90% of the areas at the periphery into the center and to get a great result. And do you need to do IVUS? I mean, I see a lot of operators doing IVUS right at the very end after the stents are deployed. But I think if you really want to do an image-guided angioplasty in the left main, you need to do intravascular ultrasonographic assessment at various levels of the angioplasty so that you can plan and go forward in a systematic fashion. And of course, calcium is a huge issue. It happens in 40 to 60%. And what is the lesson we learned in calcium? One of the serious problems in left main angioplasty is underexpansion. And this underexpansion, I want to just take this one little example of a circumflex osteum. We had assessed this in our times when we thought, okay, angiographically, not much calcium. Let me use a flextome and a 4.0 stent. This is the result I got. We had a fully expanded, you can see the stent is fully expanded. Even then, there's a little bit of a recoil in this result. This patient came back this was a flextome.
You tell him to conclude, sir.
So 8 months later, had a restenosis, and we had to do a rotational atherectomy of a 1.5 and a 2.0 stent. And this was a 4.0 stent again.
We need to, conclude because case is waiting and we're beyond time.
Okay. There's two things. When you do a non-aggressive approach on the left side, you see a cross-sectional area is very low. When you do an aggressive assessment, lesion preparation, you find better cross-sectional areas of the stent. And not only that, the stents are deformed transsectionally and the stents are symmetrical transsectionally. Of course, residual under-expanded stent is a huge problem. It repains. This just tells you that IVUS can guide you in terms of where to land. Our biggest problem is ostium of the circumflex, and sometimes it's the deformed stent which causes it. And I think imaging is mandatory, often will decide the approach and endpoint. It'll have to be an individualized approach. Lesion preparation is a key based on the images. And I think operator skill and his ability to decide and negotiate these images successfully into a procedure is the key to a good left main angioplasty. Thank you.
Thank you. Thank you very much, Kirti. Sorry to interrupt because time is running short and left main technicalities can be discussed in great length. Sarath, can we have a few questions or?
Sir, not more than a minute, sir. Just 1 minute.
Okay, sure. So now, two or three questions which had come, I'll just briefly, answer them. One of them is cardiac mortality versus all-cause mortality. Well, both are taken, but usually when we talk of death in a clinical trial of angioplasty, we could talk of cardiac mortality. But we always document the data of all-cause mortality because these are randomized trials. Both arms are sufficiently powered, and if all-cause mortality is significantly different, it can't be ignored because after all, mortality is mortality. That was the one of the problems in this Excel discussion. Then was this question about trifurcation, left main, triple kissing, and whether one guiding catheter is enough or two are required. Briefly, maybe one of the panelists can. Kirti, what do you do?
Say that again, sir. What do I do about what?
Left main to LAD, ramus, circumflex, all the three need stents. One guiding catheter, two guiding catheters.
So I typically, for these patients, I would take an 8 French guiding catheter unless there is a specific issue where we started off thinking that, okay, we'll just treat 2 of these arteries, but you end up eventually wanting to treat the third. It is very easy to put in a second guiding catheter and kind of assist in the entire procedure. You've got to remember that when you have 2 guiding catheters, it is more equipment to kind of worry about. And the more the equipment, the more likely you're getting into trouble. I think so. Keeping it simple is the key. And even if the trifurcation, true trifurcations are very few. They are close to trifurcations, and so many times the trifurcation can be subdivided into a series of bifurcations, which of course the time is not enough to kind of show you those, but many a times imaging will kind of separate the approaches and make it quite simple.
The question is answered that you may have to use 2, so you don't be shirk. Rajesh, you have to last comment on this, and then we conclude.
So, I agree with Kirti that 8 French make it very easy, and instead of say going for the 3 stent, imaging can very well go ahead and we can come out with the 2 stent for a trifurcation lesion and a balloon dilatation to one of the branch. So that's the simple strategy instead of going for a complex one using a 3 stent for a trifurcation lesion. That's my comment.
Dr. Kaul, I have a comment to make. The Excel sub-study, IVUS sub-study, Kirti, I'm sure you have also gone through it. The deformity of the stent, especially at the ostium, is one of the predicting factors for short-term as well as long-term MACE. So, and the predictor for the stent deformity at the ostium was using of 8 French guiding catheter. I'm not saying it should be completely avoided, but one has to be very cautious while pushing the guiding catheter too much inside the LM, especially after the stent has been implanted.
Sarath, if I will answer this question just in 1 minute. I think when you look at a clinical trial, there are many founding factors, and the worst part of the clinical trial of a trial and a RCT which is published is that in the publication they talk about what you started with and what you ended up with, but what they don't talk about is what happened in the cath lab to get there. And I think this is the biggest problem of clinical trials in the left main. We have been doing 8 French guiding catheters for a very long time. Initially, yes, we did damage we did distort some of and deform some of our left mains. And one of the issues with the left main proximal deformation of the stent, and I didn't cover it, which I have covered it in my previous talks, has been that we choose our stent based on LAD. So if the LAD is 3.0, then we take a 3.0 and let a large left main house a 3.0 initially, and so these Malapo stents can get extremely distorted and deformed with the touch of a guiding catheter or even with an entry of a NC balloon. But if we were to kind of rethink our strategy and start taking larger stents and deploy them at lower pressures, extending into the first branch or the second branch, then you will have more room, and that will prevent, and the first thing you do after you deploy the stent is you do a pot and establish a complete apposition of the ostium and the proximal end of the stent so that your guiding catheter will not further distort it. Opposed stents cannot be deformed. Malopposed stents can be deformed alone. And I think that is a rule, and one should remember that.
Thank you,
Thank you very
Kirti.
much.
I'll
So
ask
I
Dr.
think
Vijay Kumar Suban. Just
and
one moment, sir. Vijay, do you have any comment with your so much experience of IVUS?
I do prefer to go ahead for IVUS for most of my left main bifurcation lesion. Sometimes it's the OCT which I have also used, but then I'm more comfortable with the IVUS. So that's one thing. FFR do help for assessment of the left circumflex, osteal significance after putting a left main to LED stent. But practically speaking, I do prefer to go ahead for the imaging of the osteal L6 as well after putting the stent, how much is the area, and then to decide about osteal L6 intervention.
Okay, thank you all. We will now go to the next session, the live case from Sunshine Hospital, Hyderabad. Sridhar.
Thank you, Sarath.
Yeah, thank you so much to all the panelists, Dr. Kauls, Dr. Kirti, Vijay Kumar, and Rajesh.
And Ujjwal, I think you must be making this YouTube because it will be very interesting to distribute it, and not distribute it, people can go through this session, which is very important.
Yeah, the whole thing is on YouTube, sir. It's already there.